Alright, abdominal surgery questions. Alright, so what is used to expand the abdomen during abdominal surgery? Is this referring to open or laparoscopic surgical procedure? CO2 is used to expand the abdominal cavity during surgery, and this is used for both open and laparoscopic procedures. So CO2 gas is used to expand the abdomen during surgery, and this applies to both open and laparoscopic procedures. Next, what is the average volume required for initial pneumoperitoneum? What is the average volume required for initial pneumoperitoneum? 4 liters. List 4 side effects of CO2 use in laparoscopic surgery. List 4 side effects of CO2 use in laparoscopic surgery. So you have increased CO2, which leads to hypercarbia. Hypercarbia will lead to arrhythmia and myocardial suppression, and ultimately, potentially, embolism. So you have hypercarbia, you have myocardial suppression leading to arrhythmia, arrhythmia leading to embolism. Next, list the layers of the abdominal wall from superficial to the peritoneum. Layers of the abdominal wall from superficial to the peritoneum. So coming from superficial to deep, you have skin, subcutaneous fat, also known as Camper's fascia, and you have Scarpa's fascia, and you have external oblique, internal oblique, you have the transverse abdominis muscle, the transversalis fascia, also known as the deep fascia, then you have the preperitoneal fat, and then the peritoneum. So you have the structures that are before the muscles, you have the muscles, and you have the structures deep to the muscles. So to separate those out, you begin with the skin, and then you have 2 different types of fascia. You have the subcutaneous, so beneath the skin fascia, that's going to be the Camper's fascia. And then next you have Scarpa's fascia. So they both kind of have camp, or the C's in it, right? But Camper's is before Scarpa's. So C before S, Camper's, Scarpa's. And then you have the muscles. So you have external, and then internal, and then transverse abdominis, right? That makes sense. So again, you have skin, subcutaneous or Camper's fascia, and you have the Scarpa's fascia, and you have the 3 muscles, which are going to be external and internal obliques, followed by the transversus abdominis. Lastly, you have the structures deep to the muscular structures. You have the transversalis or the deep fascia, followed by the preperitoneal fat and the peritoneum. Next question is going to be to describe the visceral pain. What is visceral pain? Visceral pain is described as vague, poorly localized, or crampy, usually the result of smooth muscle stretch or ischemia. So it's the result of smooth muscle stretch or ischemia. So when you have cardiac ischemia, you have pretty vague symptoms. It could be generalized chest pain, you could have shoulder pain, jaw pain. So these are vague, poorly localized symptoms of ischemia. Similarly for smooth muscle stretch. A stretch is in a very specific impulse, thus you're going to have a vague description of that pain. So next question is to describe 4 causes of diffuse abdominal pain. What are 4 causes of diffuse abdominal pain? For diffuse abdominal pain, you have acute pancreatitis, diabetic ketoacidosis, early appendicitis, remember the periumbilical pain, you have gastroenteritis, intestinal obstruction, mesenteric ischemia, as well as sickle cell crisis. So you're either going to have an itis of some sort, you're going to have DKA, or you're going to have an ischemic related issue. So an intestinal obstruction, it's kind of like an ischemia of the lumen, right? The lumen is obstructed. Then you have mesenteric ischemia, or the blood supplying the mesentery, or the GI tract, followed by a sickle cell crisis, which as we know is due to lack of oxygen to the cells because of the sickle shape of the hemoglobin. That's the ischemic changes. So these are going to be causes of diffuse abdominal pain. Next is going to be 4 causes of right or left lower quadrant pain. So they would be manifests as either right or left lower quadrant pain. These include all the GU symptoms, so cystitis, endometriosis, incarcerated or strangulated hernia, inflammatory bowel disease, Mittelschmerz, and if you remember, Mittelschmerz is pain during ovulation, that's going to be Mittelschmerz. Then you have pelvic inflammatory disease, PID, due to STI typically. You have nephrolithiasis, ruptured abdominal aortic aneurysm, a ruptured ectopic pregnancy, and then last you have either testicular or ovarian torsion. And these are all going to be causes of right or left lower quadrant pain. Now we're going to have a bunch of different signs, and I want you to describe them and what condition they're associated with. So chandelier sign. What is chandelier sign? This is related to pelvic inflammatory disease. This is related to an excruciating pain that manifests during bimanual pelvic examination. The pain is so severe that the woman reaches up to motion, grabbing for the ceiling. So the pain is so bad they reach up and grab the chandelier. This signifies PID. Next you have Charcot's triad. Charcot's triad, what is that? Or Charcot's sign, I guess, but it is a triad. This is representing choledocholithiasis. This is characterized by the triad of jaundice, fever, and right upper quadrant pain. It is the result, actually, it can result in ascending cholangitis. So this blockage can lead to that ascending cholangitis, and that ascending cholangitis can manifest into Raynaud's pentad. So what are the manifestations of Raynaud's pentad? So this is going to be the sign of ascending cholangitis. So this person is going to be toxic in appearance. So they're going to have Charcot's triad, which included, if you remember, fever, jaundice, right upper quadrant pain, but they're also going to be toxic, so they're going to appear in shock, and they're going to have an altered mental status. And that is Raynaud's pentad, which is a sign of ascending cholangitis. Next you have Courvoisier sign, or Courvoisier sign, I don't know how you say it. So this is going to be periampular tumor, that's what it's going to represent. So this sign is associated with a palpable and large gallbladder, which is non-tender and often associated with a painless jaundice. So this is that pancreatitis type tumor sign where you're going to have a palpable and large gallbladder, but it's going to be non-tender and you're going to have a painless jaundice. This is likely not to be caused by cholelithiasis because it's painless jaundice, but rather it's going to be cause of a tumor. So specifically here it's going to be a periampular tumor. Next you have colon sign. What is colon sign? Colon sign is a periumbilical ecchymosis that may be present in severe necrotizing pancreatitis. So severe necrotizing pancreatitis leads to hemorrhage, which leads to retroperitoneal hemorrhage. So it's not specific for the acute pancreatitis, but it is a sign associated with acute pancreatitis as well as retroperitoneal hemorrhage. Now you have Gray-Turner sign, which is very similar, also associated with a hemorrhagic pancreatitis or an acute pancreatitis. However, this is going to manifest on the flanks. So this is going to be bruising of the flanks that are part of the body between the last rib and the tops of the hips. So that's describing where the flanks are. The bruising appears as a blue discoloration and is a sign of retroperitoneal hemorrhage or bleeding behind the peritoneum, which is the lining of the abdominal cavity. So this is similar. So colons and Gray-Turner sign are similar. Now, colon sign is going to be periumbilical, but they represent the same thing. So this is a periumbilical ecchymosis, whereas Gray-Turner sign is going to be ecchymosis of the flanks. So to turn over to see it, that's going to be Gray-Turner sign. That's going to differentiate the two, because otherwise they're pretty much the same kind of symptom, if you will, or sign. Next question is for you to describe parietal pain. So what is parietal pain? Parietal pain corresponds to the segment nerve root integrating the peritoneum. So this pain tends to be sharp and better localized. Remember, this is referring to a nerve root. Nerve roots are specific. This isn't attached to the organ system itself. So this is the nerve itself. So it's going to be better localized. So that's going to be parietal pain. Next question is going to be name two causes of right lower quadrant pain. Name two causes of right lower quadrant pain. It's going to be appendicitis and Meckel's diverticulum. So of course appendicitis, but the other one is going to be Meckel's diverticulum. And if you remember Meckel's, that occurs typically towards the distal ileum, close to that ileocecal valve. I think that's like the two feet from the ileocecal valve, something like that. That's one of the twos. So those are going to be the two causes of right lower quadrant pain: appendicitis and Meckel's. Just definitely remember appendicitis. So next, provide 3 causes of right upper quadrant pain. Provide 3 causes of right upper quadrant pain. So you're going to have cholecystitis or biliary colic. You have hepatitis or hepatic abscess, or a perforated duodenal ulcer. So you have a perforated ulcer, hepatitis, or cholecystitis. So this is just kind of thinking of what organs are in that area. You have the gallbladder, you have the liver, and then you have the duodenum. So your perforated duodenal ulcer, hepatitis, and cholecystitis. Next is to provide 2 causes of left upper quadrant pain. What are 2 causes of left upper quadrant pain? So in the left upper quadrant, there's less stuff there. You have the stomach and the spleen, really. So you're going to have gastritis and a splenic abscess. Those are going to be the 2 specific causes of left upper quadrant pain. And even 4 manifestations that can either occur in either right or left upper quadrant pain. Right or left upper quadrant pain. Here you're going to have, right in the middle, you have the pancreas, so acute pancreatitis. You have herpes zoster, which is going to be that occur in that dermatome. You have a lower lobe pneumonia. Of course, the lower lobes in the lungs, there's 2 lungs on each side. Then you have a radiculitis, as well as myocardial ischemia. And that radiculitis obviously is the radiculopathy, which occurs bilaterally. All right, back to the different signs. We have iliopsoas sign. So describe iliopsoas sign. So this can manifest due to a retrocecal abscess or appendicitis. And this is the when you're going to flex the leg upwards, a straight leg. I think I'm saying that right, flexing a straight leg, and then you're going to push down on it and see if they manifest with pain. And this is in contrast to the obturator test, which is similar, but this is going to be through passive internal rotation. And of course, both are for appendicitis. Next, you have Kerr sign. So what is Kerr sign? Kerr sign represents the hemoperitoneum, specifically referring to a splenic rupture. So Kerr sign occurs is the occurrence of acute pain in the tip of the shoulder due to the presence of blood or other irritants in the peritoneal cavity when a patient is lying down and the legs are elevated. Kerr sign in the left shoulder is considered a classic symptom of a ruptured spleen. So essentially the patient is going to be supine with a raised leg, and then they're going to feel pain in their left shoulder. So remember the left side is where the spleen is, so that's going to be caused by irritation. It's going to be a classic sign of ruptured spleen. So this is peritoneal irritation due to a ruptured spleen. Next you have Murphy's sign. What is Murphy's sign? Murphy's sign is representative of acute cholecystitis, as you know. This is going to be an inspiratory arrest that occurs upon palpation of the right upper quadrant during a deep breath. So you're going to have the patient taking a deep breath, and you're going to press down on that abdomen, and or you're going to press down, have them take a deep breath, and if they stop breathing while you're pressing down, that's going to be considered a positive Murphy's sign. Next, you have Rovsing sign. Rovsing sign, as you know, is associated with acute appendicitis, and this is going to be referred pain to the right lower quadrant with palpation of the left lower quadrant. So what type of antibiotic coverage should be considered during emergent abdominal surgery? What type of antibiotic coverage should be considered during emergent abdominal surgery? You're going to want to cover gram-negative enteric organisms as well as anaerobes. So gram-negative enterics as well as anaerobes. All right, so next question is define hematochezia. A little softball. Define hematochezia. Hematochezia is going to be bright red blood from the rectum. This may or may not be This may or may not be mixed with stool. So hematochezia, bright red blood per rectum. This may or may not be mixed with stool. Next, we're going to define melena. Melena is a foul-smelling stool, generally associated with bleeding from the upper GI tract. So this is going to be black and foul-smelling stool. This is going to be melena, whereas hematochezia is going to be bright red blood per rectum, typically due to a lower GI origin. All right, so then next, what's the most common cause of pneumoperitoneum? What's the most common cause of pneumoperitoneum? Most common cause is actually going to be a perforated ulcer. Different than what I would expected, right? Perforated ulcer. Most common cause of pneumoperitoneum. So true or false, all pneumoperitoneums require surgical intervention. All cases of pneumoperitoneum require surgical intervention. False. Non-emergent cases, such as due to colonoscopy, can be treated with bowel rest as well as IV antibiotics. However, emergent surgery is indicated in case of trauma or a ruptured viscus. When I say a ruptured viscus, I'm referring to specifically a loss of GI wall integrity resulting in a spillage of the gastric contents. So that itself would be a surgical emergency. So what procedure is characterized by gastric reduction using an endoscopic tutoring device? What procedure is characterized by suturing device. What procedure is characterized by gastric reduction using an endoscopic suturing device? This is going to be endoscopic sleeve gastroplasty. So this is going to be a suturing device. Remember, this is not cutting, it's just suturing the stomach. About 80% of it is going to be endoscopic sleeve gastroplasty. Next question. List two major steps of biliopancreatic diversion with duodenal switch. What are the two major steps of biliopancreatic diversion with duodenal switch? So first, you have the biliopancreatic diversion, right? You're going to create a sleeve gastrectomy. That's going to be part one. So sleeve gastrectomy, approximately 80% of the stomach is removed, leaving a smaller tube-shaped stomach. The pyloric valve, specifically, and a small portion of the duodenum are preserved. So that's going to be the first step, creation of a sleeve gastrectomy. Remember, this is different than the endoscopic sleeve gastroplasty, because this is actually the stomach is actually being removed, so it's a gastrectomy. And then you're going to have the duodenal switch. This is going to bypass the majority of the intestine by connecting the end portion of the intestines to the remaining duodenum near the stomach. So essentially, the first part, you're going to chop down the stomach, make about 80% go away. You're going to make a narrow tube. You're going to preserve the pyloric valve, as well as a small portion of duodenum. So that's part one, sleeve gastrectomy. Now you have the duodenal switch, or duodenal switch. This is going to be where you're going to connect that distal portion of duodenum to the distal portion of the small intestine, thus going to decrease that absorption time. Our next question, what are the benefits of biliopancreatic diversion with duodenal switch? What's the benefits? Of course, this procedure limits how much you eat and reduces the absorption of nutrients, including proteins and fats. So you can't eat as much because you have a smaller stomach, and you can't absorb as much because you have a narrow or a shorter tract down that small intestine, which is where the majority of the absorption occurs. This is kind of highlighting that right here. You have the narrow stomach with the shortened, with the pyloric valve intact, and as well as part of the duodenum. It's going to be the duodenal switch, where the small intestine is still going to connect to the ileocecal valve, however, it's going to be much narrower. All right, so gastric bypass is known as what? What is gastric bypass? This is going to be Roux-en-Y procedure, the Roux-en-Y. So describe the Roux-en-Y procedure. So essentially the Roux-en-Y procedure is you're going to kind of chop up the stomach. So you're going to create a small gastric pouch from the esophagus. You're going to exit through the esophagus, through the lower esophageal sphincter. You're going to create a gastric pouch. Then you're going to connect that gastric pouch to a part of the small intestine. This is going to be your Roux limb, right? Now the rest of that stomach that was cut off from that gastric pouch is still going to remain in there. This is going to form the biliopancreatic limb. So basically the remainder of the stomach, which is not connected to the esophagus at this point, is going to connect to the duodenum and the pancreas as normal, and then it's going to intersect at that Y intersection. That's why it's called the Roux-en-Y. So the gastric pouch empties their contents directly into the small intestine, whereas the Y intersection is used to connect the biliopancreatic limb, all those gastric juices coming from the stomach, the pancreas, all that. It's going to meet over here at that Y intersection and allow food to digest a little bit better than otherwise. So what two scoring systems can be used to rate disease severity in acute pancreatitis? So what two scoring systems can be used to rate disease severity in acute pancreatitis? You have the Ranson's criteria as well as Apache 2 score. Ranson's criteria and Apache 2 score. So you don't need to go into detail here, just note that these two scores, Ranson's and Apache, they are used to rate the disease severity in acute pancreatitis. They essentially rate just how critical a disease is in general. They're not specific for pancreatitis. True or false, all these cases of acute pancreatitis require a surgical intervention. All cases of acute pancreatitis require surgical intervention. No, nothing is all, right? False, more cases are self-limited and resolve spontaneously. Surgical treatment is reserved for complications of the disease process. Such complications include necrotic areas, pseudocyst, pancreatic abscess, or hemorrhage. So most are self-limiting and require no intervention. However, surgical treatment is indicated for certain complications, including necrotic hemorrhage, pseudocyst, pancreatic abscess, or of course hemorrhage. So what is the most common type of pancreatic cancer, as well as what are two risk factors? So the most common type of pancreatic cancer and then two risk factors. So the most common type is going to be ductal adenocarcinoma, which is typically found on the head of the pancreas. And the two risk factors are going to be increased age and cigarette smoking. So ductal adenocarcinoma, typically found at the head of the pancreas, often caused by increased age and cigarette smoking. So what are two clinical signs of pancreatic cancer? What are two clinical signs of pancreatic cancer? You have Courvoisier sign as well as colon sign. Courvoisier sign as well as colon sign. Now if you remember, Courvoisier sign is going to be, so this doesn't make a whole lot of sense to me. So the two clinical signs of pancreatic cancer, Courvoisier's and colons. Courvoisier's, yes, that's the palpable gallbladder that occurs with a painless jaundice. That's clearly an indication of a pancreatic cancer or periampular tumor. However, colon sign, I'm not really sure why I have this here, so it could be an error or could have just been listed on the PowerPoint. Either way, if you remember, colon sign is that periumbilical ecchymosis that occurs typically due to a peritoneal hemorrhage or acute appendicitis. So how do you diagnose and treat pancreatic cancer? How do you diagnose and treat pancreatic cancer? ERCP is used for diagnosis, followed by a pancreaticoduodenectomy. So a pancreaticoduodenectomy, so removal of the head of the pancreas as well as the duodenum. This is going to be the Whipple procedure. This is used for resectable tumors in the head of the pancreas. So you have this image here where the head of the pancreas is removed, as well as most of the duodenum. Actually, I guess all of the duodenum. You have the common bile duct, it connects here, and you kind of get the idea. Not really too important to know the exact anatomy of how it works. So next question, a patient who undergoes splenectomy is at risk from infection from what three organism? What three organisms at risk in a patient post-splenectomy? And then what is the treatment? So they are at risk for encapsulated bacteria. Such encapsulated bacteria include strep pneumo, H. flu, and Neisseria meningitidis. So strep pneumo, H. flu, Neisseria meningitidis. Treatment is going to be vancomycin and ceftriaxone. So remember, you have strep pneumo, gram-positive, H. flu, gram-negative, Neisseria, also gram-negative. So you need to cover with a gram-positive vancomycin as well as a gram-negative ceftriaxone. So what vaccination should be given to all patients post-splenectomy or functionally asplenic? So we just said that they're at risk from encapsulated bacteria, specifically strep pneumo, H. flu, and Neisseria. So you're going to want to give the pneumovax, the H. flu vaccine, as well as the meningitis vaccine. So that makes sense. A 62-year-old male with a 20-pack history presents complaining of a 4-month history of worsening abdominal pain. The patient also notes itchy skin and a 10-pound weight loss. On physical exam, you notice a yellow tinge in his eyes as well as a purple, blue discoloration around his umbilicus. What is the most likely diagnosis? Pancreatic cancer. So here we have itchy skin, so that jaundice that occurs. Yellow tinge, also the pruritus due to the increased bilirubin, and then the jaundice is the yellowing. And then you have colon sign here. It's the colon sign. So just to review, they had a 4-month history of worsening abdominal pain, so non-specific, right? But they note itchy skin, so you're thinking increased bilirubin, a 10-pound weight loss, so you're thinking a cancer, and then you have a yellow tinge in the eye, so jaundice, as well as a colon sign or the blue discoloration around the umbilicus. You should be thinking pancreatic origin, specifically pancreatic cancer here due to that weight loss. So next you're going to be describe the pathophysiology of acute pancreatitis. Describe the pathophysiology of acute pancreatitis. So this is going to be acinar cell injury. So the pancreatic cell injury results in intracellular activation of pancreatic enzymes. Remember they house those enzymes. So you have injury and those enzymes will become activated and they are digestible enzymes. So they're going to auto-digest the pancreas. Thus it just kind of eats itself. And then what are the most common cause of acute pancreatitis? Those are going to be alcoholism and as well as gallstones. So alcoholism and gallstones account for 80-90%. And then a small majority here is going to be high triglycerides. All right, so what is the most common congenital abnormality of the small intestine? What is the most common congenital abnormality of the small intestine? You can have Meckel's diverticulum. This occurs the diverticulum contains all three layers of the GI tract, the mucosa, submucosa, and muscularis propria. And you have the, and if you remember, Meckel's is caused by failure of vitelline duct obliteration in utero. This is going to be the rules of 2% of the population, 2 inches in length, presents within the first 2 years of life, located 2 feet from the ileocecal valve, contains 2 types of mucosa, as well as 2% of individuals affected become symptomatic. So how are you going to diagnose Meckel's diverticulum? How are you going to diagnose Meckel's? This can be a Tectenium 99 scan. Tectenium 99. What is the most common worldwide cause of small bowel obstruction? What about in Western nations? So the most common worldwide is going to be hernia. However, in Western nations, it's going to be due to post-surgical adhesions. What are 2 types of small bowel obstruction? 2 types of small bowel obstruction. You have non-mechanical and mechanical. Non-mechanical is going to be due to paralytic, which is a dynamic ileus in which peristalsis is inhibited. Paralytic ileus is most commonly caused by medications, trauma, or surgery. And then the second type is going to be mechanical. This is going to be intramural obstruction or external pressure on the bowel. This is going to be typically due to adhesions, specifically in the Western nation. So non-mechanical is going to be to paralysis or loss of peristalsis. So think of like a Hirschsprung's. And then mechanical, you have something like adhesions leading to a small bowel obstruction. So next question, you have a 45-year-old male with a significant abdominal surgical history, presents with diffuse abdominal tenderness for 3 days. On physical exam, you note abdominal distension, tympany due to percussion, and a high-pitched bowel sound. Abdominal X-ray shows a string of pearls appearance as well as a stacked coins pattern of dilation. What is the most likely diagnosis and best treatment? So this is going to be a small bowel obstruction due to adhesions. The string of pearls represents an air fluid level, and the stack of coins pattern represents dilation or thickened dilated bowel loops greater than or equal to 4 millimeters. Treatment is going to be IV fluids, NG tube decompression, continue at a low continuous section, or if no improvement within 24 to 48 hours, the option for surgical exploration is available. All right, so what is the most common cause of acute appendicitis? Most common cause of acute appendicitis? Typically due to obstruction of the appendiceal lumen, often due to lymphoid hyperplasia preceded by a viral illness. So essentially lymphoid hyperplasia. So a viral illness leads to hyperplasia of the lymphoid tissue there. That'll lead to obstruction. Obstruction leads to fluid buildup, which leads to infection, that whole circle of life type thing. Also, the second most common cause is going to be a fecal lift. Fecal lift accounts for 35%. 60% is going to be to lymphoid hyperplasia, most commonly due to viral illness. So describe the physiologic progression of appendicitis. Describe the physiologic progression of appendicitis. You're going to begin with ulceration, necrosis, progressing to gangrene, and ultimately perforation. So you have ulceration that leads to necrosis, leads to gangrene, and then ultimately perforation. So injury, dying, dead, broken, essentially. What disease is characterized by transmural inflammation of the bowel that can occur from mouth to anus? So transmural inflammation of the bowel from mouth to anus, Crohn's disease. So transmural, not typically associated with bleeding. When medical management fails or when complications occur, what is the surgical procedure of choice for ulcerative colitis? So once medical management fails or when complications occur, what surgical procedure is choice for ulcerative colitis? A total colectomy with mucosal proctectomy and ileoanal pull-through, or IAPP. So total colectomy, so removing the entire colon with mucosal proctectomy and ileoanal pull-through. So basically you're pulling up the anus to the ileum and getting rid of the colon. What are the two most common sites for volvulus formation? The two most common sites for volvulus formation, you have the sigmoid colon as well as the cecum. Sigmoid colon and the cecum. So the right and left sides, kind of really. Abdominal radiography, you see a coffee or a kidney bean sign. What is the most likely diagnosis? It's going to be a volvulus. So that kidney bean sign or coffee bean is going to be a volvulus. What distinguishes the anus from the rectum? So what distinguishes the anus from the rectum? The dentate line. It's located 2 centimeters from the anal verge. Delineates where sensory fibers end. Also delineates where sensory fibers ends. So again, the dentate line is what separates the anus from the rectum. Remember, the anus is not considered the rectum. So the dentate line, which is located 2 centimeters from the anal verge, or where I guess the butthole begins. I'm not really sure another way to put that. And this is also going to be where sensory fibers end, that dentate line. So describe 4 classifications of internal hemorrhoids. Describe 4 classifications of internal hemorrhoids. So you're going to have first, second, third, and fourth degree. So first is when there's a bulge in the anal canal lumen, however there's no protrusion. So this is just the easiest one. So kind of a bulging into the anal canal, but no protrusion. Remember, these are all for internal hemorrhoids. And then second degree is going to be a protrudes during defecation. However, it goes back spontaneously. So they just each kind of progress. Now the second one is it protrudes with defecation again, but the next step up, but it needs manual reduction. And lastly, it's going to be permanent protrusion. It's going to be incarcerated. You can't get it pushed back regardless. So the first one is you have a bulge, like a little bump, but no protrusion. The second one is going to be protrusion during defecation or when straining, however it reduces spontaneously. Third is going to be protrusion during defecation, which needs manual reduction. And then fourth is going to be permanent protrusion that becomes incarcerated. So treatment is going to be various based on the grade. So first is going to be, if symptomatic, you could do a rubber band ligation. But if they're asymptomatic, a bulking agent, basically better bowel habits is really what's going to be successful first degree. Second and third degree, you could do a rubber band ligation or a surgery for third degree, but rubber band ligation is probably the best option. And then fourth, you have surgery, a hemorrhoidectomy. What is the cause of perirectal abscess? What is the most common cause of perirectal abscess? Obstruction of the anal glands. So that makes sense. Obstruction leads to infection. So obstruction of the anal glands leads to a perirectal abscess. What are 3 types of perirectal abscess? What are 3 types of perirectal abscess? You have a perianal abscess, you have an ischiorectal abscess, and the supralevator abscess. So perianal abscess must be differentiated from the deeper form of perirectal abscess. Remember, perianal is going to be the most superficial. Then you have the ischiorectal abscess, which may form from purulent drainage tracking across the external anal sphincter into the deep ischiorectal fossa. So it can lead to purulent drainage tracking across the external anal sphincter into the deep ischiorenal fossa. And you have supralevator abscess. And this kind of shows you an image here. So you have the perianal abscess, which is the most superficial, which needs to be differentiated from the other two. And then you have the ischiorector and the supralevator. So the supralevator is going to be essentially above this supralevator muscle, right? And then you have the ischiorectal, which is between the ischium bone and the rectum. So pretty self-explanatory based on where they're at. And that's it. That's a little long one, but you held in there, so good job.